and welcome to this Ask the Expert activity in COPD. I'm Dr. Sarah Sungurlu, an Associate Program Director of the Pulmonary and Critical Care Fellowship Program, as well as Assistant Professor of Medicine at Montefiore Einstein. Today, I'll answer some of your most common questions regarding COPD. Let's get started. We all have had those patients who have emphysema and chronic bronchitis symptoms, but their FEV1 FVC is greater than 70 or even 80%. So by gold standards, they would not have COPD. There seems to be a gap in our ability to diagnose early COPD. Is there any place for oscillometry or high-resolution CT to diagnose COPD earlier, especially in those patients with symptoms? So this is an area that has a lot of interest right now, and there's a lot of ongoing COPD research in these specific questions. So I'm going to kind of separate it based off the questions. Regarding the impulse oscillometry, which that's like a complementary study to spirometry, that's especially useful in our patients who have physical or mental disorders or those that limit their ability to perform the maneuvers of spirometry. It measures mechanical properties during their tidal breathing by utilizing sinusoidal pressure variations, and that allows their flow response. So that's the big utilization of impulse oscillometry. It is certainly extremely helpful in our patients who can't participate and cannot perform spirometry. However, there are limitations to it, and that's the reason it's not incorporated in our guidelines right now. The sensitivity remains its biggest limitation. There are various studies that look at whether or not it can be used, and they've had very inconsistent results, and that's the reason that at this time it's not incorporated. I personally do think there is a role of impulse oscillometry, especially, again, my patients who are unable to perform the traditional spirometry. I typically do not utilize it at this point outside of those patients. Regarding the question about the high-resolution CT scan, this is actually kind of interesting because, again, there's a lot of things coming out about changing the guidelines and changing how we're diagnosing COPD. And many of you may have seen that in JAMA, they recently published data from the COPD gene cohort with the BOT group. And they looked at basically 10,000 participants and made a new diagnostic schema for COPD that they proposed. And this now is incorporating things beyond spirometry because of exactly what you said, those patients that were missing. The new schema includes things such as the respiratory symptoms, their chest imaging, and it does still incorporate spirometry. And they found using this new criteria for diagnosis of COPD or this new schema that the patients that they diagnosed with the new criteria did have a faster decline in FEV1, more frequent exacerbations, and greater all-cause and respiratory mortality. And so for this reason, they're proposing that, again, that the guidelines actually change and that we now incorporate things. Yes, we still have the major criteria of spirometry, but if a patient doesn't meet the COPD diagnosis by that major criteria, they may be able to meet it by 3 minor criteria, which includes presence of emphysema, bronchial wall thickening, as well as the dyspnea or quality of life and bronchitis symptoms. So clearly, this is something that, I think we're going to hear more and more about. And then it's very possible that this may be, brought into the GOLD and ATS and ERS guidelines in the upcoming year. It's something that, the BAT group and the COPD gene project, they have 10,000 patients. So it's something that is highly studied at this point. I think the biggest limitation is that, right now a traditional CT only shows our large and intermediate airways, and it can be visualized. You can do bronchial wall measurements manually. So the theoretical benefit of that high resolution CT scan that you mentioned is that it allows thinner cuts, but the cuts are spaced out further. And therefore, you might be able to get early involvement of the small airways and might be able to have more chances for finding regional gas trapping or even quantitatively analyze emphysema. realistically, high resolution CT scan and a lot of the other advanced imaging methods that have been studied in COPD, which includes like micro CT, photo counting, PET CT, even CT densitometry, which is used mostly for lung volume reduction. All of these modes do have benefits and are able to pick up on things such as the terminal bronchioles or the more distal airways that traditional CT is missing. But at this point, they're still under investigation, and they obviously are a huge resource. And so we're not routinely relying on these for the diagnosis. I think we're going to see the change based off of the BOT study regarding traditional CTs incorporated. I don't anticipate that anytime soon we'll have the incorporation of these more advanced therapies. But again, it goes to point on that in COPD, as we've seen over the years, we're constantly learning more about the disease and the progression, and we are therefore changing our diagnostics, including, the addition of PRISM or the preserved ratio impaired spirometry, as well as pre-COPD in the past couple of years. So the second question, how soon after hospital discharge should spirometry be repeated? This, again, there's no specific guideline on how often it should be performed in COPD. Generally, after the initial diagnosis, it is recommended if there's a change in symptoms to help determine if the change can be attributed to obstruction. So often we'll see spirometry redone in that position when a patient is having a decline in their symptoms, and we're looking for whether it's truly their COPD or an alternative diagnosis. The other utility of the spirometry outside of course diagnostics is to determine the qualification for advanced therapies such as pulmonary rehabilitation, lung volume reduction, transplantation. Gold actually does make a suggestion that you should consider repeating at least annual spirometry on patients, mainly to help identify your patients who are having a rapid decline in their values. But regarding the specific question of when do you do a spirometry after an acute exacerbation, really there's no clear guidance on this as well. And there have been multiple studies on this as well that have been, variable results. Some studies have even looked at doing spirometry inpatient versus at the, right prior to discharge. And I'd say that the most common limitation is that the reliability of the study can be present, meaning it's a concern that if the patient isn't giving their maximum effort because they're not feeling well, or if the patient isn't, maybe a little encephalopathic from the steroids or the illness, or even if they're not able to sit up in the upright position in the bed and be coached by the respiratory therapist adequately, the quality of the data is going to be inadequate. And likewise, the therapist that is performing the data has to have the time to really evaluate the quality of that study. For that reason, the utilization of inpatient spirometry is something that I think we will see potentially used, especially in the role of trying to identify our COPD patients or confirm the diagnosis of COPD while they're still inpatient. Because as we discussed, one of the limitations of our COPD exacerbations is the rate of re-exacerbation is so high. And unfortunately, sometimes our patients aren't able to be seen within the time period prior to their readmission and obtain that initial spirometry that we need to confirm the diagnosis. And of course, we do want to confirm that this is truly COPD that is causing them to get hospitalized to begin with. The alternative, if we aren't doing inpatient spirometry, which again is not routinely advised and not routinely done, is to do the spirometry on discharge. And as far as that timing goes, the guidelines do say try to get the patient to their theoretical baseline. And again, in the GOLD criteria, they do specifically recommend 12 to 16 weeks after discharge to consider spirometry. That way we're getting their post-exacerbation baseline for prognostication. But even that, I will say clinically, you'll see quite a wide variety. And there is no, yes, this is absolutely the right time versus no. I think you'll see a lot of variety based off of resources. The main thing that you want to decide or use to help you decide whether spirometry is appropriate is if this is truly to diagnose the patient and confirm your suspicion of COPD, it may be okay to do it earlier and get that baseline spirometry. While if you're using it for prognostication, you may have to take into account that their spirometry may improve theoretically once they're back to their baseline lung function after recovery from the exacerbation. Now, the third question, when should inhaled corticosteroids be added for triple therapy and when should it be withdrawn? Inhaled corticosteroids as far as the addition goes, we already covered that pretty heavily. So again, we want to consider an inhaled corticosteroids based off the GOLD criteria in a patient who is group E, meaning they're having those frequent exacerbations, whether it's 2 outpatient or 1 inpatient. And the patient that benefits from the steroids versus just dual therapy alone are those that have that eosinophil count of greater than 300. So again, a group E patient with an eosinophil count of 300 should be initiated at that point on triple therapy, including inhaled corticosteroids. Additionally, if a patient was group E and initially didn't qualify for the addition of inhaled corticosteroids by that criteria of 300, you might consider adding it still if they come back with another exacerbation while on dual therapy. And now you can reduce your criteria down to that 100 criteria cutoff for the eosinophil count. I always point out that there are a few other caveats or things to consider clinically in the addition of inhaled corticosteroids. And that's mainly the question of whether or not you suspect asthma in the patient. Because some of our patients who are more of the asthma phenotype, of course, we would recommend inhaled corticosteroids more aggressively in those patients. And additionally, the other caveat that I think should be considered is if your eosinophil count is being, drawn or collected after the addition of steroids has already been there, the steroids may suppress the eosinophil response. And therefore, you don't want to only rely on the eosinophils in that case. That is, kind of a personal and clinical guidance. You look at the patient and decide based off of their overall syndrome, but by the criteria, we're using that 300 eosinophil cutoff as our indicator. Now, the question is really asking, when do we withdraw the inhaled corticosteroids, which is, really a very different question. And the withdrawal, if we remember from the talk, the risk of inhaled corticosteroids is risk of pneumonia. This is the biggest concern that we have. So our risk of pneumonia can be much higher in our inhaled corticosteroid using patients. And so those who are having frequent pneumonias or are colonized with some kind of bacteria, including AFB, are the patients that we should really consider withdrawing the inhaled corticosteroids because of that risk of pneumonia that they have. Outside of those cases, there's been many studies on the withdrawal of inhaled corticosteroids, even prior to the newest guidelines of doing triple therapy, meaning when we were looking at the TORCH trial and things like that. But basically, we found that the studies showed increase in exacerbations and symptoms with the withdrawal of inhaled corticosteroids compared to maintaining on triple therapy. And so there is evidence that it's a modest decrease, but a decrease of FEV1 with patients who withdraw inhaled corticosteroid. And for that reason, if a patient qualified for triple therapy and is having no contraindications for continuing the inhaled corticosteroid, we don't recommend the removal of inhaled corticosteroids unless something changes. Now, how long should patients stay on a biologic therapy, and would you step down your inhaled therapy if they're well controlled on biologic? Again, these are great questions because these are questions that we don't fully know the answer to at this point. And so I would say overall, it's similar to withdrawal, where withdrawal of ICS, I should say, where it's something that I think, we're investigating. We know dupilumab and now mepolizumab are newly approved drugs for COPD. And there's a lot of ongoing research that are going for their role in COPD. I think the best we can do right now is try to extrapolate from asthma, where we know that it is sometimes feasible to withdraw biologics in asthmatics in certain patient populations. The biggest thing is these super responders we see in asthma are less likely to occur in COPD because of the pathology of the disease. So it is, extrapolating and knowing the physiology. I would say I expect that we're going to find that if a patient benefits from a biologic, it's going to be hard to determine that it's ever, the right time to withdraw a biologic. But at this point, we don't have enough data to say that. And I would say that even if you're doing a trial of a biologic for that patient that qualifies, so that 300 or higher eosinophil exacerbations, even in those patients, it's hard to determine the timeline of exactly how long you should trial before determining if there's a clinical benefit. We know biologics takes weeks to months for effect, and it's hard to say, are they not feeling better because they just haven't had enough time on the drug versus are they not going to have a clinical response to the drug? And so even in that setting, I would say give it at least a few months or, consider doing several months of therapy. And only if the patient is still having exacerbations and feels really no benefit of the biologics, should you consider discontinuing in that situation. This is really, again, extrapolating from asthma data. And at this time, I don't think we have the guidance to say what's going to happen in COPD. Thank you for joining me today. I hope you found this Ask the Expert session helpful. For more educational resources and links to other CME activities, please visit www.exchangecme.com.